that. Without further ado, research to practice, updates in surgical management for breast cancer with Dr. Gallagher, DOFACOS, FACS. Dr. Gallagher, welcome.
Thank you. I'm happy to be here.
Good. We're happy to have you here. Thank you so much. Let's see. We're going to just, there's our basic bio information, but we're going to go through a few things here. And co-PI for national clinical trial to reduce the incidence of lymphedema for patients undergoing lymph node surgery. Number 4, she was awarded Best Abstract in 2019 by the Association of Academic Surgery. Congratulations. Loves teaching students, residents, and fellows. And a surgical coach and helps to train other surgeons nationally in oncoplastic surgical techniques. And trained in oncoplastic surgery, so every surgery she attempts to hide scars and rearrange tissues so that it makes things look as natural as possible.
Yes.
Great. Well, and what's something we should know outside of your professional bio about you?
Yeah. So I'm a mom of a toddler, and
oh my gosh.
She definitely consumes most of my life outside of work.
I'll bet.
But she is the light of my life, and we have so much fun.
Wow.
It's a good age.
Oh, what
I think
fun.
All ages are good.
They are. They're all good. Some are easier than others. That is a very funny. Good for you. Good for you. Let's see. I mentioned poll everywhere, so the question that we'll be asking, breast surgery is a common treatment that can involve removing cancer, removing lymph nodes, or reconstructing the breast. This is true, false. We try to make these first ones pretty easy. So I will flash up our disclosures, and now we can take a look and see if you'll please go ahead and respond to that. And we'll give you a few more seconds. We'll usually give you 10, 15, 20 seconds to respond to these questions. Dr. Gallagher, we seem to be settling in on true. Are they doing all right?
I think they're doing great so far.
Well, without further ado, updates in the surgical management of breast cancer, June 26, 2024. I'll turn the controls over to you and let you take it from here.
All right. Well, again, thank you so much for the opportunity to talk about something I am passionate about. Certainly, this lecture is going to be focusing mostly on updates. There is a lot of information with breast cancer. Things continuously change and lots of clinical trials. So I have no relevant disclosures pertaining to this lecture. And the big things we're going to focus on today, we're going to talk a lot about surgical management of the breast, some of the clinical trials that have shaped what we do today, and some of the current ones that are shaping how we treat breast cancer moving forward. We'll talk a little bit about axillary management. This is continuously changing. And I tell, my residents, my fellows, like what I did with the axilla 2 years ago, 5 years ago is vastly different than sometimes what I'm offering today. So a lot of clinical trials and research that have been dedicated to this topic. Finally, we're going to talk a little bit about something that I'm passionate about, which is preventing lymphedema and looking at a surgical approach that we can minimize that, because it's a really big complication that breast cancer patients, if they develop it, have a lot of trouble with. And so if we can prevent it, that's really better for the patient. Future direction, we're going to be sprinkling in all of these topics. And so as we go, we'll talk about things that are on the horizon and what that means for the future. So when we think about surgical management of the breast, really there are two options for patients. Breast conservation, or what we call a lumpectomy or a partial mastectomy, where we actually save the breast. We take out the cancer, but the rest of the breast remains, versus mastectomy, where the entire breast is removed. Those are kind of the two options. And then I throw in oncoplastic techniques, because this is something that is relatively new. And I say that it's becoming more popularized, but these techniques can be applied to either lumpectomy or to mastectomy. So we'll talk about that. Just a little bit of historical perspective, because I think it's always important to know kind of where we came from so that we can see where we're going. You can see here in the late 1800s, radical mastectomy was considered standard of care and actually was named the gold standard. And this was really a morbid operation. So this is in the days when we thought that surgery could cure breast cancer, just surgery alone. And so these operations were extensive. All of the breast, the chest wall, the muscles, the skin, the lymph nodes in the region, everything was removed. And what happens is it's a really morbid operation. So patients had really bad side effects. They often had skin grafts to cover their chest. They developed lymphedema. And it, again, was just a very morbid operation. And then it took a really long time to figure out that maybe less surgery is better. And so in the 70s, NSABP B04 actually asked the question as, could we do less surgery? And so at that point in time, we were doing what's called a modified radical mastectomy, where the breast was removed, some of the skin, but not all of the skin, as well as the axillary lymph nodes. And then along the same time, kind of also in the 70s, NSABP B06 asked, well, can we do even less surgery in the breast? Could we save the breast and just remove the cancer? And what we found with all of these clinical trials is that the overall survival was the same. So doing less surgery actually, or doing more aggressive surgery, didn't make patients live any longer. Certainly kind of paired with this, we want to think about, okay, well, we know survival didn't change based on these studies, but what about local recurrence? And so that is something that, we need to think about. So with lumpectomy, we frequently add radiation to kind of minimize the risk of that local regional recurrence. Now, I know you are going to have a lecture coming up later this year specifically on radiation, and so I'm going to kind of focus a little bit more on the surgical aspect, but I think it's important to talk a little bit about radiation too, because surgery and radiation are for what we call local control, and so they're really entwined and paired together. This is the Early Breast Cancer Trialist Collaborative Group, and they reported a meta-analysis on 10,000 women. They used 17 randomized trials looking at the effect of radiotherapy after breast-conserving surgery on the 10-year recurrence and the 15-year recurrence and breast cancer death. And you can see kind of in that first picture there, breast-conserving surgery alone at 10 years yielded a local regional recurrence of about 35% compared to the addition of breast-conserving surgery with radiation. And so you could reduce that local regional recurrence to 19.3%, so almost half the recurrence. And you can see kind of in the graph in the middle, when you're thinking about breast cancer death, the addition of radiation actually reduced breast cancer associated morbidity, and that actually was about a sixth the risk. So adding radiation, we know with these clinical trials, significantly reduces breast cancer coming back. So real quick, just look at the bottom. The years of these clinical trials, right, is really important because the years are between, all of these trials are accruing between 1976 and 1999. So this data is really old. And why that's important is during that time, or since that time, we have a lot of treatment that has really developed. So we have changes in surgical management. We're now paying attention to margins. We have better imaging studies. We have ways that we can kind of target and tailor radiation. And then most importantly, we have new systemic treatments, which help with distant control, but also help to reduce the local regional recurrence rates. And so these numbers are actually pretty high compared to more modern series. So when you think about modern series, it actually shows that we have a much lower risk of local regional recurrence. And so most modern series say that the risk of a local regional recurrence after breast conserving surgery is about 5 to 15% compared to that historical 9 to 35% for ipsilateral breast tumor recurrence. And there's several factors that we know are associated with the risk of tumor recurrence. One, certainly age at diagnosis. The younger the patient is at the diagnosis, the higher the risk of developing a future recurrence. You can see the graph on the right. It shows a higher risk for women under 50. So those bottom two curves, right, are for women over 50, 50 and over, and they're pretty even. But you can see as the age decreases, right, your local risk of recurrence is much higher. And in fact, it's as high as 35% for women before the age of 35. Other factors are going to be tumor grade, so a high grade will increase in a higher risk of local recurrence. Receptor status, so more aggressive phenotypes like triple negative and HER2 positive. An extensive intracapsular extension or kind of intraductal component, an extensive intraductal component increases the risk of breast cancer local recurrence. Adjuvant therapy is extremely important. We know the use of radiotherapy reduces the risk of local recurrence, but we also have to think about compliance with endocrine therapy because some of these medications are really hard to take. Same receipt for chemotherapy and other targeted therapies. So what the patient is willing to accept as part of their treatment will affect their local regional recurrence. So which is better, lumpectomy or mastectomy? And this is a kind of a hot topic because traditionally, in fact, even last year in my clinic, I was counseling patients that lumpectomy is equal to mastectomy in terms of overall survival because all of the older data, this is what we're taught, and that when I say overall survival, what I tell patients is choosing a more aggressive surgery does not make you live any longer. But then when it comes to local regional recurrence, which is always the follow-up question, well, what's my chance of it coming back? Historically, based on those studies, we said that mastectomy actually had a lower risk of a local regional recurrence compared to lumpectomy or breast conservation. And what we now know is this is not true. This study came out within the last year, and it's really practice changing. It was presented at the ASBRS, so our national meeting this year, as one of the best papers. And this was a retrospective review of a prospectively maintained database from 2006 to 2016. It included patients with T1 to T3, so some pretty big tumors, and N0 to N3, so heavy axillary burden in patients who had breast cancer. Now, it excluded women over 70 because we know that some women over 70 may not need radiation, and so it did exclude that patient population. It excluded bilateral breast cancer, synchronous ipsilateral cancers, receipt of neoadjuvant chemotherapy, or de novo stage 4 disease. And there were a lot of patients that were included, just under 14,000 patients. And you can see in the curve that breast-conserving surgery results in a better overall survival than mastectomy, and that mastectomy was associated with an increased risk of death. They actually separated out the node negative and node positive, and so you can see the node negative trends on the top and the node positive on the bottom. And this trend is true for both groups. So breast conservation also resulted in an improved breast cancer-specific survival, and there was no difference, I'm going to say it again, no difference in local regional recurrence. This is much different than if you look at those early breast cancer trials. And this is something we now need to kind of start to change in the spiel whenever we're talking with patients about what their options are. So the next logical question is, are we over-treating patients, right? Are we telling them that their fear of recurrence is a reason to choose mastectomy? And we just saw that in the series, that's not actually true. So we do need to change our counseling to say that there may be reasons to opt for mastectomy, but improvement in local control should not be one of them. Moreover, maybe survival is improved with breast conservation, and there's a whole host of ideas about why this may be, but none of them have actually been proven. So in conclusion, in an era of more contemporary systemic therapy, more effective imaging, because with additional imaging, we're hopefully not missing more disease, and so we can plan a better surgery. We have more focused radiation. We have equivalent local regional control and improved survival for patients undergoing breast conservation compared to mastectomy. So the seminal randomized controlled trials demonstrated historically that BCT was equivalent to mastectomy. However, this is old data, and it also historically said they had an increased risk of local regional recurrence. There are multiple other studies that have confirmed that even in young patients, high-risk tumors, and even node-positive patients, this isn't true. And so BCT still improves survival even in these high-risk populations. So some possible explanations as far as why patients are living longer, right, with breast conservation compared to mastectomy. And some of the proposed ideas are mastectomy induces a larger inflammatory response. Mastectomy can delay the initiation of adjuvant treatment. So if a patient has a complication, if they develop like long-term seroma or need to keep their drain in for a prolonged period of time, it could delay systemic therapy and or radiation. And then what about local regional recurrence? Like why are they now equal? Like we thought historically removing that breast tissue, right? It just made sense. You had less breast tissue, less chance to recur. So how is that equal? Now we have much better diagnostic imaging, which delineates the extent of disease, so we're planning our surgeries better. We have better margin assessment. Many of us are using intraoperative margin assessment to make sure that everything is removed during the initial surgery as much as possible. There's more precise radiation techniques and significantly, and this is probably the big one, significantly improved systemic treatment options. And all this just, again, demonstrates that it's tumor biology that is the driver and not the extent of surgery that is really important. So it's certainly time to update our counseling of how we manage these patients and what we tell them during these conversations. So our next question, is radiation necessary for all patients undergoing breast conserving surgery?
All right, and it looks like some folks already jumped in and answered that, which is great. If for some reason, once in a while, we catch the last question, and so if that happened to you, you can, there's a little place where you can, I think it's a little trash can, you can deselect your one answer and put in the other. We'll give them a few more seconds. And so we're trending 83% on no and 16 on yes. We have great attendance, by the way. We've got over 100 folks attending live today.
Oh, that's wonderful.
So, how are they doing?
They're doing great. Yes, that is it is not always necessary, and we're gonna talk about that. So, randomized controlled, radiation, the addition of radiation, we have already talked about with all of those trials, reduces the risk of local regional recurrence by half and cancer death rates by a sixth. But as we know, breast cancer is a heterogeneous disease, and the absolute benefit is going to vary for individual patients. Radiation, just like surgery, right, is not benign. It has potential side effects. And those include breast pain, fibrosis, cardiac mortality, although they do some really great things to try to minimize this risk. You can develop lymphedema of both the breast and or the arm just from radiation alone. And then sometimes it results in a poorer cosmetic result. And then rarely radiation-induced sarcoma. I will say that our radiation oncology colleagues are fantastic, and they really do their absolute best to minimize these potential side effects and risks. This is actually a patient who it looks like she's had a mastectomy and reconstruction with an implant on that right side, and it turns out she actually had a lumpectomy. And so all of that tissue is fibrotic, and it's due to the radiation change. So then the follow-up question is, are there patients who are unlikely to benefit from radiation, and can we avoid morbidity and cost in the patients who have no or very little benefit? So these are the randomized trials that have been conducted to define these kind of more low-risk subgroups, the patients who might be able to omit radiation. And you can see the majority of patients are over age 50 with stage 1 hormone receptor positive and non-high-grade early breast cancer. You'll see at the bottom there's a high local recurrence rates that were observed in the earlier randomized trials. So these are things like BO6. Although the more recent trials confirmed and established, you can see the lower recurrence rates, but they still confirmed and established that the effect of radiation in decreasing local regional recurrence is significant. There really are two landmark clinical trials that provide the evidence base for national and international guidelines for omitting radiation in certain patient populations after breast-conserving surgery. The CALGB 9343 was a randomized controlled trial, included 647 patients from 1994 to 1999. It included patients who were greater than 70, ER positive, and clinical stage 1. And it randomized patients to tamoxifen alone or tamoxifen plus radiation. They reported their 10-year plus results back in 2013, and they saw no reduction in disease-free survival or mastectomy-free survival in those populations. They did see a small reduction in local regional recurrence with the addition of radiation. But then again, the question is this actually meaningful, right, in a patient population who's greater than 70, as there were no improvements in overall survival. The second trial is Prime 2, and this was reported, the long-term 10-year results were reported this past year in the New England Journal of Medicine. And this trial included about 1,300 patients from 2003 to 2009. Inclusion criteria were very similar. They did go down to age 65, and they included both T1 or T2 tumors that were less than 3 centimeters. All patients in this one had breast-conserving surgery. They were required to have clear or negative margins, and they had to plan to have endocrine therapy. They were randomized to either whole breast radiation or no radiation, and the median follow-up was 9 years. And so you can see the cumulative local regional recurrence rate in the no radiation group was 9.5 compared to 0.9 in the radiation group. So again, a reduction in local regional recurrence. The 10-year cumulative incidence of distant recurrence is a little bit lower, and you can see, just like CALGB, the breast cancer specific survival and the overall survival, there really wasn't any change. So the investigators concluded omission of radiotherapy was associated with an increased incident of local recurrence, but had no detrimental effect on distant recurrence as the first event or overall survival among patients 65 years of age or older in low-risk, hormone receptor positive early breast cancer. And then I guess the question is, like, next, where are we going? And so this is just a list of trials that are actually looking to try to tailor therapy a little bit more. So using genomic assays and prognostic indicators to see if we can individualize treatment for patients to see who might be a better candidate for consideration of de-escalating therapy. This is a trial here at UNC. This is Dr. Casey, who you're going to be hearing about later this year, or hearing from later this year. All those trials we talked about, all patients took endocrine therapy and were just randomized to whether or not they got radiation. Well, endocrine therapy, we talked about, is sometimes hard to take. Not all patients are compliant. It's a pill that you take every day, at least for 5 years. And so the question is, would it be better to do a short term of, partial breast radiation instead of committing to medication? And so inclusion criteria are very similar to those two trials, and patients are randomized to either accelerated partial breast irradiation or endocrine therapy. This is currently open here at UNC, and so I'm eager to see those results when they are available. So next question, should repeat lumpectomy ever be considered? So you have a patient who had a prior lumpectomy and radiation, and now they're back in your clinic. Can we redo a lumpectomy?
All right, and thank you so much to everyone for jumping in. And I should have mentioned earlier, I do usually, these are all anonymous, so we're not grading anyone. We're not tracking your response other than to say thank you to folks for responding. So great number of responses so far. Dr. Gallagher, we're heavily trending on yes. How are they doing?
They're doing great. Yes is the correct answer. And it certainly is a multidisciplinary discussion. But so can you repeat a lumpectomy? Historically, we would say absolutely not. You can only have radiation once, and you cannot have a second lumpectomy. But we know there is increasing interest in de-escalating surgical management for appropriate patient populations. So in 2021, the group of experts met at St. Gallen Conference to discuss how to best approach surgical management of recurrence. And what they discussed is that mastectomy should no longer be considered mandatory or obligatory for an ipsilateral breast tumor recurrence. They did try to suggest which patients would have the best outcome for repeat breast conserving surgery, and they recommended consideration for low-risk breast cancers who had small hormone receptor positive tumors and those who were more than 5 years out from their primary treatment. The panel was split 50-50 on whether a redo lumpectomy should be considered if repeat radiation was not an option. This is a study at MSK showing that over the last 20 years, the rate of breast conserving surgery and redo lumpectomy is steadily increasing for women with a breast cancer recurrence. It was higher in women who were older and those who were hormone receptor positive compared to hormone receptor negative. So this is already in practice and is increasingly being used. There are many SEER studies that also have reported safety. This is a meta-analysis, including 42 observational studies, and they looked at the second rate of a local regional recurrence, and they found after redo lumpectomy, the recurrence for a second recurrence was 15.7%, and after salvage mastectomy, it was 10.3%. This is the forest plot that shows that those women who had salvage mastectomy had slightly worse overall survival, although we do have to be careful how to interpret this data because it is a small effect. However, we are seeing a theme that mastectomy in general has been associated with a worse survival compared to lumpectomy. There did not appear to be any effects on radiotherapy in terms of outcome. So in conclusion, they said repeat breast conserving surgery could be considered as an alternative to mastectomy for an ipsilateral breast tumor recurrence, as it does not appear to be associated with adverse overall survival outcomes. But we do need to be careful with patient selection, and every decision should be made in partnership with our patients and the multidisciplinary team. So this is the NCCN guidelines because we always go back to what the standard of care is. And so this is treatment of local regional recurrence. And you can see the top line there. Repeat lumpectomy is an option, especially if they have not received prior radiation. So if you have a patient who met the PRIME 2 or CALGB criteria, they're an excellent candidate to consider repeat lumpectomy. Again, it is a multidisciplinary discussion. So oncoplastic surgery, this is really my passion. This is something that I love and am passionate about, is improving cosmetic outcomes. And this is so important for patients because every day when they wake up, they're looking in the mirror, and if 2 years, 5 years, 10 years down the road, all they can see are the scars, they're going to be continuously reminded that they had a breast cancer and a breast cancer surgery. And so we really try to improve the cosmesis for our patients as much as possible. So what is oncoplastic surgery? It's when a cancer surgery or an oncologic surgery and a plastic reconstructive surgery are combined in a single operation. And so how this is done, it can be very simple. When you remove the cancer, it may just involve reshaping the breast so that it looks like a normal appearance. Things that are really important is, we want to get the cancer out. We want to make sure that the tumor has been removed. But secondarily, and really kind of almost a primary secondary goal, should be satisfactory cosmetic outcome. Cosmetic outcomes are associated with patient satisfaction and improved quality of life. And a study showed that poor outcomes affect about 40% of patients undergoing lumpectomy, which is really high. We really need to work hard to get this number down. And it showed that there is a direct correlation between cosmetic outcome and patient anxiety and depression score, body image, sexuality, and self-esteem. So some factors influencing cosmesis for surgery, things that I think about whenever I'm planning a surgery is, where am I going to put the incision? How much tissue do I need to remove? And if it's quite a bit, is there a way that I can do volume replacement so that they don't have a dimple or a divot? Sometimes this can be just simple tissue rearrangement. Other times you need kind of more extensive volume replacement surgery. And then where is the tumor located? Certainly adjuvant therapy is something to consider, because we talked about radiation can influence cosmesis with fibrosis. And so if I have a fatty replaced breast versus kind of a dense glandular breast, that might change my approach. And then systemic therapies. Incisions can be done a lot of ways. I think my go-to really is that periareolar incision, just because it tends to hide things so nicely. Also an inframammary incision, so below the breast, that also is a great option. Sometimes you have cancers that involve the skin or come up close proximity to the skin, and you have to make an incision directly over. So in general, if I'm in kind of that upper half of the breast, I'm thinking more of a curvilinear incision versus the lower half, more of a radial incision to hide that. And then I always want to try to avoid that V neckline because patients are going to be wearing, potentially low-cut shirts. And so if I can avoid that upper inner quadrant, I will really, do my best to minimize an incision in that area. So here's just some examples. You can see kind of inframammary incision that hides nicely in the middle. There's a periareolar. If you bring that incision just right inside of that color change, many times your eyes are drawn to the color change and it just misses the scar. So again, that's one of my favorites. The picture on the right is actually a patient who had skin involvement and quite a bit of skin involvement kind of along the medial inframammary fold. And so we were able to do a parallelogram incision, take the involved skin, reshape the breast, and then hide that scar along that fold. So again, being thoughtful, thinking about, a lot of planning goes into these cancer operations. This is a patient who had a cancer that was right under the areola. It did not involve the nipple. So many times if we have something close to the nipple, we would think about removing the nipple and doing a central lumpectomy. But since the nipple itself was fine, we did a radial incision. We removed the area of the nipple, or the area of the areola that was involved. And you can see on the right, you have a nice round areola, so it's going to heal in just beautifully. Lots of ways to reshape the breast. Some breast surgeons are trained in these oncoplastic techniques. Others partner with their plastic surgery colleagues. So there's lots of ways to accomplish this, even if the surgeon isn't comfortable doing them themselves. This is one of my patients. So she had a breast cancer on the left breast, kind of right in the middle of kind of where that purple line is. And it turns out it was actually a perfect location, because if we were going to do a cosmetic breast reduction, that was the area that would normally be removed. And so we were able to do a large volume resection and a breast reduction at the same time. And this is her about a week later with nice glandular fullness. And, this is a patient who's a cancer patient, right? But then also gets a cosmetic surgery that's life-changing that she's always wanted. This is a patient who was born or developed kind of asymmetry of the breast just naturally. I tell all my patients breasts are sisters, not twins, occasionally distant cousins. So both breasts are rarely identical. But she developed a breast cancer on the side that was larger, and that had always bothered her. And so we were able to do kind of a lift at the same time, some volume displacement to make her symmetrical. And I showed the picture in the middle just because right after surgery, the breast is quite often very swollen and boxy, but about 3 to 6 months later, that swelling will resolve, and you can see her a year out on the photo of the right, and she's very happy and symmetrical. I always say, when patients are happy when they come back with their bikini lines, and they've been happily at the beach. So can we apply these same principles to mastectomy? There is a growing movement for aesthetically flat closures. And so you can. It just kind of takes some planning to figure out how to contour that chest wall, but I think it's really important to do so. Again, this movement, why go flat? Maybe it's to avoid additional surgeries. Maybe patients they're sick and they don't want, they want to minimize their surgical time. They don't want a foreign body. They want to lower their risk of complications, or they just don't want to wear a shirt. Whether or not they have reconstruction, that decision is a personal one. And going flat does not mean they're not interested in still achieving a good result. This was a study, a patient-reported outcome online survey of 931 women that was really eye-opening. The top reasons for them going flat were they didn't want a foreign body placed, and then they desired a faster recovery. 65% of the respondents felt that they received adequate information about their surgical options so that they could make the right decision, so that's good. But that means about 20% of the respondents felt that their surgeon did not respect or support their decision to go flat. And that's really heartbreaking. We need to do a better job of supporting our patients. In a multivariate analysis, low level of surgeon support for the decision to go flat was the strongest predictor of low satisfaction score, and a greater satisfaction was associated with the patients who did feel like they received adequate information about their options. I put this in just because these are actually some of the quotes from the paper. I was never given the choice to go flat. It was like I was expected to have reconstruction. And then the one that kind of breaks my heart, I stated multiple times I intended to stay flat. And after surgery, they told me they left an extra skin just in case I changed my mind. We really, again, have to make these shared decision-making. We have to respect our patients' desires. So it's important for us as healthcare providers to do so. Flat mastectomies and small breasts, sometimes you can get away with a shorter incision. Sometimes you need to extend a little bit just to contour. Everybody is very individual and unique. This is, I think the larger breasts sometimes are a little harder, and you can see, in addition to the breast, sometimes that tissue will extend back under the arm and kind of onto the back with like a little axillary roll. We call this the angel wing technique. We say it's an angel wing, and I jokingly say, we'll take away your wing but leave your halo. Patients tend to like that. But this is kind of what that technique looks like. And so even with a larger breast, it is possible to achieve a nice cosmetic result. Same, even for patients who want reconstruction, the same principles can be applied. This is a patient we did kind of a breast reduction, skin envelope reduction, and an implant at the same time, so it just fits that implant nicely. And then for nipple sparing, making sure you're hiding those scars. So we'll switch gears a little bit and talk a little bit about the surgical management of the axilla. I think we have a poll everywhere, maybe.
Let's see. Let's advance one more. There we go.
Oh, perfect. Oh, but it doesn't have the leading question. Can I go back?
Yes, I'm sorry. Somehow we missed
Sorry.
the question
That's okay.
with the answers.
All right, so a 41-year-old patient you're going to see in your clinic with a 2.5 centimeter breast cancer, ERPR positive, HER2 negative. She's planning for a lumpectomy. On exam, she doesn't have any axillary adenopathy, so a T2 N0 clinically. What axillary surgery would you recommend?
I think we actually just ran out of room to fit all the text in there is why we did that.
Sorry.
So, all right. So A, no axillary surgery. B, sentinel lymph node biopsy, excision, or C, axillary lymph node dissection. Take about another 5 seconds.
It's looking good.
All right. So we're going with B?
We're going with B. Sentinel lymph node is correct. So what is a clinically negative axilla? So clinically negative is when you do an exam and you don't feel any suspicious lymph nodes. However, lots of studies have shown that's about a 50% accuracy. And the reason is, every axilla is different. If you have a patient, with a BMI of 18, well, you may be able to feel everything and anything. Whereas if you have a patient with a much higher BMI, it's going to be really challenging to feel what you need to. Axillary ultrasound is also very helpful to kind of evaluate the axilla, especially in these more challenging cases. So sentinel lymph node excision was the standard of care for many years for invasive cancer. It certainly, and it still is the standard of care for clinically node negative patients. It certainly can help direct systemic treatment recommendations and adjuvant treatment recommendations as far as medications and radiation. But there are times we consider omitting or not doing any axillary surgery. So we talked about the PRIME2 and the CALGB trials earlier, which omitted radiation, and kind of some of that extrapolation is, well, can we consider omitting a sentinel if we're not going to be doing radiation for these patients who are a little bit older, have tumors less than 3 centimeters, favorable pathology, and a negative exam? And in the CALGB study, many of those patients didn't have axillary evaluation. And so as a community, we had already started doing this with kind of the Choosing Wisely campaign. And then I wanted to mention, too, the SOUND trial is something that just came out, but it included any age, mostly age 50, 60, tumors less than 2 centimeters, favorable phenotypes, negative axillary ultrasound. And so it was kind of the first randomized trial that kind of asked this question. Just for those who don't know what a sentinel is, you're going to be injecting a tracer into the breast to find that first draining lymph node, so that you can, and it could be one, it could be several, it's wherever that tracer drains. And this has been around since the late 90s, early 2000s. So again, the SOUND trial, 1,400 patients with breast cancer less than 2 centimeters and a negative axillary ultrasound were randomized to sentinel versus no axillary surgery. And in this randomized clinical trial, omission of axillary surgery was non-inferior to sentinel lymph node biopsy in patients with small breast cancer and a negative result on ultrasound. These results suggest that patients with these features can be safely spared any axillary surgery whenever the lack of pathological information does not affect the post-operative treatment plan. And this is really kind of where your multidisciplinary discussions are so critically important, because if that nodal information is going to direct adjuvant treatment, then it may be worthwhile to get it. This is a trial that's been around for a really long time, Z11, but it really is kind of one of the seminal trials looking at what do we do for patients who were clinically node negative, and then we find a surprise at the time of surgery and they actually are node positive. Historically, all of those patients would be subjected to an axillary dissection, but this clinical trial looked at patients T1 to 2 with 1 or 2 positive sentinel lymph nodes. The patients were all getting lumpectomy with planned whole breast radiation. And what they found is after they did sentinel and followed by axillary dissection, the 27% of patients still had residual positive nodes, which makes you say, well, if the groups are even, and they should be, the patients who didn't get an axillary dissection and just got radiation also probably had about a 20% chance of having residual positive nodes. There was some controversy with this as far as the radiation treatment. The trial was designed to only get whole breast radiation, but several of the sites did include regional nodal radiation and high tangents. Later, they did address that kind of in a subset analysis, and they did not see any significant difference. And with 10-year follow-up, they concluded there's no role for an axillary dissection for patients with a positive node, otherwise meeting the Z11 criteria.
All right. And this is another one of those poll everywheres where we needed 2 slides to
Okay.
put everything.
I'm going to read the question. So this is a 52-year-old, 4-centimeter triple negative breast cancer who has a positive lymph node. She underwent chemotherapy and had an excellent response. On imaging, the breast cancer is no longer visible and the lymph node now has a normal appearance. She's planning for a lumpectomy in her breast, but the question is what to do in her axilla. So node positive before chemotherapy with a good response.
Well, we have plenty of activity. Appreciate all the
great.
different responses. And take about another 5 seconds or so. Again, if you're not sure, put in your best guess. Right, Dr. Gallagher, how are they doing?
Good, good. So this historically and actually still is a little bit of a hot topic. In fact, I was on a panel this weekend with a debate about to clip or not to clip. So yes, sentinel and targeted axillary dissection are both correct, but we'll talk about some of the nuances. So for node-positive patients after neoadjuvant chemotherapy, there were some clinical trials that looked at this 1071, Centina, SNFNAC, and what they did is they did sentinel followed by axillary lymph node dissection, and really the goal was to determine what the overall false negative rate was. Way back whenever they did the trials for sentinel, they kind of threw out this theoretical kind of cutoff of 10%. So if you have a less than 10% false negative rate, that was their goal to have a positive trial. And as you can see, the overall false negative rate was close, right? But it was over the 10%. Certainly, whenever they kind of looked into some more technique, then you could reduce that false negative rate. And I will say that false negative rate certainly was an arbitrary number. So even though it's close, it didn't quite meet that threshold. If you use 2 agents, so the mapping agents are kind of what we talked about when you inject the breast. Some people were using 1, some people were using 2. If you use dual agent, you can reduce that false negative rate kind of to that 10% or less, and then the number of lymph nodes removed at the time of surgery really significantly reduced it. So if you can get 3 or more sentinel lymph nodes, you can further reduce that rate. Unfortunately, even with dual tracer, you don't always get 3 or more sentinel lymph nodes. It really is dependent on anatomy and where that breast drains. And so they did a subgroup analysis because some patients were getting clips in their lymph node that was previously biopsied. And so they looked at, well, what about the lymph node that was positive before chemotherapy? If we clip it and we remove it, what's our false negative rate? And they found that the false negative rate dropped to 6.8%. So this kind of spurred the TAD trial, MD Anderson group. They included 191 patients. They looked at the false negative rate for the clipped node alone, which was 4.2% versus the sentinel alone, which was 10%. And then when you add both the sentinel and the clipped node, you can reduce that false negative rate to 1.2%. Here at UNC, we did a very similar study around the same time. The difference was we did just the clip node because we thought, prognostically it makes the most sense. The node that was positive, if you take it out and you see what the response is, prognostically that may give you the most information. And we found that the false negative rate was 5.1% when just the clip node was removed, which is similar to the MD Anderson group. The one thing that we did that was a little different is we looked at the feasibility. So is it possible if you clip a node to then retrieve it out back? And we found if you place your reflector or your whatever localizing agent that you use before chemotherapy, we had a 100% chance of retrieving that node out back. Unfortunately, if that localizer did not get placed at the time of either the biopsy or before chemotherapy, and after chemotherapy that node had responded, it's much more challenging to find. And so the feasibility in that case was 90%. So if you are going to be clipping nodes, you really want to localize it before chemotherapy. All right, so this is, I think, the same patient as before, 4-centimeter triple negative breast cancer, chemotherapy. She had a great response. She's now completed her lumpectomy. You did the TAD plus sentinel, and her final pathology shows she has 2 of 3 nodes that are still involved with cancer. The largest metastasis was 9 millimeters, so she's still node positive after the sentinel and TAD. What surgery should she have?
All right, and I'll just mention that as soon as we're done with this last question, if our audience wants to go ahead and start submitting questions, poll everywhere, we'll flip over to take questions in just a moment.
Perfect.
All right, how are they doing?
Good, good. So yes, currently axillary lymph node dissection is the answer. However, there is a clinical trial, A11202, that is evaluating this, similar to kind of a Z11 concept of after chemotherapy, do you always need to dissect this, or will radiation take care of it? This trial is close to accrual, and so we are eagerly waiting for the results. And then I just threw this in. This was a study done here at UNC by Dr. Spanheimer and my colleagues and Gray Puri, who we just looked at the NCDB database, and we're finding that a lot of people are already kind of putting this into practice. And so then just the very last thing I wanted to talk about was lymphedema. Lymphedema can be really troublesome, right? It can develop days to 30 years after surgery, and many patients fear that even worse than the mastectomy. There certainly are non-controllable and controllable factors. Certainly the controllable, include cancer treatment, but the biggest one is surgery. And so there's a technique that we do here at UNC called axillary reverse mapping. We know that the mapping in the breast is possible, and so this just allows us to inject the arm with blue dye so that during dissection we can still remove everything that drains the breast, but we can visualize the lymphatics that drain the arm and save them. This is just a picture of it in the operating room, and you can kind of see that blue lymphatic channel. On the left at the bottom, there is a node that actually has a lymphatic channel, and so you don't want to compromise an oncologic surgery. And so if that lymph node is blue and needs to be removed, you can dissect out actually the afferent, efferent lymphatics, and then after it's removed, you can see the picture on the right with the suture. You can tie them back together. This is very effective. It reduces the risk of lymphedema with sentinel from that 1 to 3% to 0.8%, and for an axillary dissection from about 20% down to about 6%, so significant. And then the follow-up is if you reanastomose. This is, again, small numbers. Nothing's probably going to ever be 0, but on a single institution, if you did tie them back together, they reduced it, and it was 0% at 24 months. Again, small numbers. A221702 is a national clinical trial, which I'm actually one of the co-PIs on. It just finished accrual, and so we are also awaiting the results of this. Hopefully it will be practice-changing. These are the amazing people that I get to work with every day, so a big thank you to them. And I'm happy to take questions.
All right, Dr. Gallagher, this has been just amazing. Thank you so much. I'll go ahead and pop that up. And while we're waiting for questions to come in, You talked about the multidisciplinary tumor boards, and our team actually has the good fortune to be able to help support the technology for those. Would you describe a little bit about what takes place in a multidisciplinary tumor board here at UNC?
Absolutely. So all new breast cancers that come in, we present cases, and so as a group, it used to be in person, and now it's kind of more virtual since COVID, which has actually been helpful because people who couldn't come in person actually can join. But everyone talks about, we review all the pathology, we review the imaging, we review kind of recommendations. We have geneticists, radiation oncologists, medical oncologists, surgeons, research teams. So everybody is there reviewing things and making recommendations for patients. And so, you come to UNC for, potentially a second opinion with one person, but really you're getting the opinion of the entire group, which is fantastic.
Yeah, it's a very inspiring process, and we're glad to be a part of that. Let me ask, let me just make sure that we should, that's all. Oh, we did just get a question. Oops, not yet. I think they're leading up to one. So while we're waiting for others, BRCA1 and BRCA2 gene mutations, you talked about mastectomy versus lumpectomy. Does this have any impact at all? I know we've heard a lot in the news over the years about patients having mastectomy sometimes in advance of any diagnosis. Where does this fit with the more recent research about lumpectomies and mastectomies?
Yeah, certainly, our gene mutation carriers are going to be a little bit more unique because their risk of having future breast cancers, even after, developing a breast cancer, is going to be potentially much higher.
Right.
A lot of it depends on what gene they test positive for. And so it really kind of is a discussion that you have with your team.
Okay.
Current recommendations are either to do high-risk screening with kind of mammograms and MRIs, and we rotate those every 6 months.
Okay.
The thought process is with that, we're not treating a breast cancer or a future breast cancer, but we're hopefully finding something that's small enough that we can treat it at an earlier stage.
Gotcha.
Certainly the alternative would be to consider risk reduction prophylactic mastectomies for those patients.
Gotcha. Thank you so much. Let's see. Here we go. We do have a question. How does fibrosis from RT negatively affect patients?
Yeah, great question. Fibrosis is kind of like, I describe it as scar tissue sort of in the breast. You can have a very small amount of fibrosis and maybe it doesn't affect patients on their daily life, or you can get significant changes. And so I showed that picture of the patient who had a lot of fibrosis, right? And it's all just, it's hard as a rock. It can be very painful. There are medications and things that we can do to try to minimize some of those changes. Rarely, we have to consider kind of more surgical management, like a mastectomy, just to treat it if it really gets bad.
Gotcha. Thank you. And I don't think we have any more questions at this point, and we are at the hour. So let me share a few things to wrap up. We want to thank State of North Carolina, the funding of the University Cancer Research Fund that makes this series possible, the UNC Lineberger Cancer Network, the team here at UNC Lineberger Cancer Network, and that's Benny Obore, John Powell, Oliver Marth, Andrew Dodson, Patrick Muscarella, Lindsay Reich, and Barbara Walsh for all the hard work they do for each and every one of these lectures.